everyone. I'm Dr. Karthikeyan. I'm a consulting physician and chief medical officer from Jawar Hospital, Ramanathapuram. I am here to share few things about latest updates in hypertension. Hypertension is ranked third most risk factor for burden of diseases in South Asia, a public health burden on cardiovascular health status and healthcare systems in India. According to the World Health Organization, total deaths in India due to non-communicable diseases is 63%. In this 63%, nearly 27% are cardiovascular diseases, and it affects to 40 to 69 age group people by around 45%. Raised blood pressure is one of the most important risk factors for cardiovascular diseases, but it remains poorly controlled due to lack of awareness and a lack of primary care and poor follow-up. In India, the prevalence in last 30 years has gone over from 29% in men to 38%, and from 28% to 32% in women. Apart from this, nearly half the population of hypertensive people are unaware of their condition. Also, those with hypertension, more than 60% of men and 53% in women did not get proper treatment. Only 1 in 5 men and 1 in 4 women are using medication for hypertensive control worldwide. International Society of Hypertension, they released 2020 Global Hypertensive Practice Guidelines. It includes optimal and essential treatment model attempts to address the resource poor settings. Optimal care is evidence-based standard of care, and essential care is minimum standard of care. The scientific statement released by American Heart Association in 2021 for the management of stage 1 hypertension among those with low atherosclerotic cardiovascular disease states that pharmacologic therapy should be considered only after 3 to 6 months of non-pharmacological therapy like lifestyle modification, physical activities, etc., and only when the BP remains uncontrolled. In acute respiratory distress syndrome, a potentially fatal condition causing lung damage and the expose associated often with the severe COVID-19. A recent study on American College of Cardiology reports that use of metoprolol can reduce lung inflammation and improve respiration in people with COVID-19 induced ARDS. Lowering systolic blood pressure to 10 to 130 millimeters mercury reduce cardiovascular adverse events in step randomized trial. Among 8,500 patients in age group 60 to 80 in China, it trimmed 26% of cardiovascular risk, and now another major trial supporting these claims from the US professional societies range from the threshold of 130 to 150 millimeter of mercury. International Society of Hypertension released a 2020 global most people require lifelong medical management for hypertensive control. In 2008 European guidelines, it recommends 5 classes of antihypertensives as recommended. Considering high non-adherence to treatment, importance of combination therapy to improve adherence and BP control, it recommends to start with antihypertensive therapy with initial fixed dose of angiotensin converting enzymes of class 1, ARBs with the calcium channel blockers or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. This is because of the identification of carcinogen NDMA, N-nitrosodimethylamine, which is classified by WHO's International Agency of Cancer Research as carcinogenic in humans. It is largely accumulated in a manufacturing site in Zhejiang, China, where the highest level of concentration of the contaminant is found. If 1 lakh people receive valsartan from taking highest doses of valsartan every day for at least 6 years, it results in causing additional 22 liver cancers over their lifetime. But valsartan record is now accompanied by significant increase in emergency department admissions by 6%. With regards to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, 2018 European guidelines recommend diagnostics should not be dependent only on office BP, but also on out of office BP measurements, such as home blood pressure monitoring. 24 hours and nighttime BP measurements are associated with the risk of mortality and cardiovascular outcome. For every increase in 10 to 20 millimeter of mercury in BP measurements at night, risk of mortality increases by 23% and cardiovascular events by 36%. The HYGEA study represents largest study that tested nighttime antihypertensive therapy. In this trial, chronotherapy associated with significant reduction in endpoints, including death. It tested nighttime chronotherapy with the usual awakening therapy, which included 19,000 patients. The relative risk reduction for cardiovascular events significantly improved for nighttime treatment when compared with awakening treatment. And thank you for sparing your time. I thank Lupin for giving this opportunity. So eat a healthy diet, do exercise at least 5 days in a week, and stay away from hypertension. Thank you.